today I'm going to talk about ischemic cardiomyopathy assessment by MRI and talk about viability assessment and stress perfusion MRI as well. I have no disclosures. When we talk about CMR and ischemic heart disease, we talk about a few indications. One is we want to know what the plaque burden is in the patient, and the second is, does this patient have chest pain that is from coronary artery disease? So how can we assess ischemic heart disease with CMR? We have myocardial perfusion imaging, we have viability assessment, we have function and prognosis, and we can assess myocardial infarction and the complications, and I'll go over all of these. First, we start with ischemic cascade. So here we have the temporal sequence of events. This is what happens at rest. There's nothing going on. That's what happens normally. When there's stress or decreased blood flow to the heart, we first see a perfusion defect. So that's where CMR perfusion comes into place. Then we see metabolic alteration. After that, diastolic dysfunction. Then next we have regional wall motion abnormality. That is what we can catch in typically our echo as well as CMR cine images, which I'll go over. Then we have systolic dysfunction. That's when our EF starts decreasing. And then ECG changes. And finally, we have chest pain. After a patient has chest pain, we get to see CMR delayed enhancement. For a CMR viability study, we want to start with getting an IV in the patient. We have the patient go into the scanner, and we take cine images. We inject the contrast after that, and then wait 5 to 10 minutes and get delayed enhancement images. No stress agent is required for just a viability study. So we have different ways of assessing myocardial viability and ischemia. We have PET, metabolic activity of the heart is assessed. Then we have SPECT thallium, where we can assess if there's hibernating myocardium. Dobutamine stress echo to see if there's any contractile reserve. And then CMR LGE scar imaging, which I'll go over in more detail. But to note, CMR is the only technique that is able to directly image the infarction and the scar. So this is a slide showing histopathology and LGE correlation. This was done in a dog model where the LAD artery was occluded repeatedly. So here you can take a closer look and see that in this histopathology slide, there's an infarct in the septum and anterior wall in the LAD territory. And this is the MRI of the exact same position. And the pattern of LGE here is very similar to what's seen in histopathology. So as Dr. Deepaben described, ischemic hyperenhancement patterns can happen in two styles. Subendocardial infarct, which is in the subendocardium involving less than 50% of the wall thickness, and then transmural infarct, which is more than 50% of the wall thickness involvement. So this is how the LGE pattern appears. So only 25 to 50% of the wall thickness is involved. This white is the scar. Here we have transmural infarct, and this white pattern here in the anterior and anteroseptal wall is scar. So let's go over a case. We have a 40-year-old man with history of hypertension, diabetes, hyperlipidemia with typical anginal symptoms over 1 year. Let me play the video again. Which coronary artery has significant disease for this patient? So there's wall motion in the anterior wall, the septum, and also here in the anterolateral wall. So does this patient have LAD disease, right coronary, left circumflex, or diffuse coronary artery disease? On LGE imaging, there's delayed enhancement extending from the anterior wall, anteroseptum, inferoseptum, as well as inferior wall in the basal segment. And towards the mid, it's also extending to the inferolateral wall. So here we can see that there's LAD involvement in the anterior anteroseptum, inferior wall indicating RCA, coronary artery involvement, as well as inferolateral wall, which could be the left circumflex. So this patient had diffuse CAD. MRI is very good in differentiated ischemic versus non-ischemic cardiomyopathy based on the pattern of subendocardial and transmural infarct. So chronic heart failure due to ischemic etiology almost always is associated with CAD pattern of LGE. This is another case. 65-year-old woman with typical angina gets a coronary angiogram, which shows a single vessel disease of the LAD, proximal stenosis of 90 to 99%. What would be the best next step of management for this patient? Just medical management? Refer for a stent to the LAD? Refer for a bypass surgery? Or do you need more information? So here we can see that their EF is reduced. There is transmural scar in the anterior wall as well as the anteroseptum. Transmural means that this LAD area is not viable and the patient would not necessarily benefit from a stent. So that's where transmural extent of hyperenhancement is inversely related to the likelihood of improvement of the wall motion. So for example, if a patient has no delayed enhancement, there's 80% likelihood that their wall motion will improve. And if the patient has more than 76%, it's more than likely it will not improve. Another case, a 72-year-old woman presents to the emergency room with chest pain, shortness of breath, history of hypertension, diabetes on insulin, negative troponins, negative BNP. Abnormal EKG with Q waves, ST changes. Here we have our cine images by MRI, which show that there is a wall motion in the inferior wall. Here we have delayed enhancement of the inferior wall, which shows RCA distribution. This is stress MRI, where we inject a vasodilator, stress the patient, and inject contrast. Here you can see that there's also a defect in the inferolateral and anterolateral walls, which indicate that there's also circumflex involvement. So the angiogram for this patient, the LAD had total occlusion, but it did have significant collateral supplying it. Left circumflex also had significant lesions, and RCA also had a total occlusion. But because of the collaterals, there was flow to the LAD, and only the left circumflex area had decreased blood flow or ischemia on stress. So another case, a 71-year-old man with known 3-vessel disease, but lost to follow-up. He had worsening symptoms for 8 months and came to the hospital 8 times in the last 8 months. This is his angiogram, severe 3-vessel disease, total occlusion of the RCA. LAD had sequential 80-90% lesions, and also the left circumflex had severe lesions. There were collaterals from the LAD to the RCA. These are the short axis stacks. You can see that the patient has almost less than 20% ejection fraction with lots of wall motion abnormality. There's also some MR, there's LV dilatation. What do you think the late gadolinium enhancement will show? Will the myocardium be viable or non-viable? Should we do something for this patient? So surprisingly and interestingly, this patient only had infarct, these white portions, in the anteroseptum, inferoseptum, in the mid walls, and no other scar. What we also found was that there was an LV thrombus that you can see here. As a part of the injection of the contrast, we get an MR angiogram, and we can see the distal aorta is also totally occluded. So what would be the best step for this patient? He has viable myocardium, but he has significant disease. Ultimately, this patient did undergo revascularization with stents, with support from a device, Impella device, and ECMO. And the last case I have here is 65-year-old man with ischemic cardiomyopathy, LVEF 35 to 40% with a history of bypass 6 months ago, atrial fibrillation with worsening dyspnea. So this is a cine image 4-chamber view, and here you can see that in the ventricular septum there's a defect. In the short axis view, you can see more clearly that there's a defect of VSD with a contained aneurysm. This was a complication of the patient's MI and bypass surgery. So we could catch this late complication in MRI as well. So going back to MRI and ischemic heart disease, we can do myocardial perfusion, the stress imaging. We can look for viability. Is there going to be benefit of revascularization in the patient? We can look at the LV function and get an idea of prognosis, as well as look at the extent of myocardial infarction and complications. And again, a slide where we can differentiate where ischemic versus non-ischemic. Both have their own specific patterns to help recognize. So the advantages of MRI: no image quality limitations from body habitus like we see in echo. There's no radiation or nephrotoxic contrast. The gadolinium does not harm the kidneys. You can obtain identical slices at each stage. You can see direct scar assessment with delayed enhancement imaging and differentiate viable versus non-viable myocardium. Thank you. This is my team at Houston Methodist.